Welcome to the Bright Side of Aging program. My name is Ike Engelbaum. I'm a pharmacist and the publisher of the American Senior Gazette.org. The reason I do this program is to promote the positive aspects of aging. In fact, a couple of my favorite sayings are that age is a matter of the mind. If you don't mind, it doesn't matter. You cannot help getting older, but you can help getting old. I try to bring out in this program tips on health care as you age. I also try to give you tips that you should try to live life in a vertical position for as long as your good genes allow. And if you've inherited bad genes, how to outwit them. And I try to find professionals that really help me in that mission. And one of my favorite people to deal with is our guest, Agustin Arbulu. And Agustin, you like to be called Aggie? Is that
Aggie.
Right? Aggie,
Good seeing you, Ike.
And Aggie is president of Metro Home Care, Metro Palliative Care, Metro Hospice, and Metro Personal Care, and they're headquartered in Farmington Hills, serving Livingston, Macomb, Oakland, and Wayne counties. They offer a full continuum of home-based services such as skilled home health care, palliative care, and hospice care in the home setting. Agustin works closely on developing strategic partnerships between health entities. Agustin also works closely with a post-acute care network offering seamless care from inpatient discharge, that means hospital or SNF settings, back to home. And whether there's a senior apartment setting, appropriate setting for him, or assisted living setting, that's what Agustin does. He helps you in that whole transition. For the past 30 years plus, I'll call you Augie, has been involved in a number of civic and community-related organizations. He served as president and founder of the Hispanic Bar of Michigan and Hispanic Business Alliance, HBA. He has also served on various boards, including the Boys and Girls Clubs of Southeast Michigan, Leadership Detroit, and Lyric Chamber Ensemble. Presently, Agustin serves on the Board of Trustees and a member of the Finance Committee of St. Joe's Oakland Hospital. He's also been an inductee and member of the HBA's Hall of Fame. Agustin's educational background and work experience includes having practiced law and having served as an educator at the graduate college level. His educational background includes an executive doctorate in management and a master in business administration and a Juris Doctor and LLM in taxation. Agustin, what is LLM?
A Master's of Law in Taxation.
I see. All right.
Good to see you, Ike.
It's good to have you here.
Thank you for having me.
I am impressed. You've got such an array of talents, and in the healthcare field, I guess you need almost all of that stuff. Is that right?
Well, I think until the recent past, the healthcare system was really fragmented, and you almost needed as many degrees as you could to be able to walk through the system, to go from one line or one silo to the next silo to the next silo to the next silo. So that is something that is changing. Families and their loved ones who need care, we need to be able to respond to that need. The focus is how do we address the needs of the patient where we find the patient. And that patient could be found in the home, could be found in a hospital, could be found in a nursing facility, could be found in assisted living. How do we provide the necessary services to address that patient's need? That's critical in today's marketplace.
Now, you've addressed quite a few different topics there, and I'm just wondering, in the hierarchy of challenges that children of the elderly have, Is there any sort of a hierarchy that you feel does have some sort of a sequential type situation?
That's a great question. What ends up happening is with the baby boomers turning 65, it's really not our concern currently about the baby boomers, but it's really about the parents of the baby boomers that we're concerned with, because people are living longer. So the baby boomers need a way to access information. And candidly, we haven't totally developed a one-stop resource center where a individual, a child of an elder parent can call and saying, hi Ike, this is John, I need some help for my parents, and let me tell you what it's about. And you're able to take that information and turn it around and address those concerns. That, I think, is coming. I know that at Metro we work really hard as being a one-stop resource center, so that if a parent calls, a child of a parent calls, we're able to respond to the needs of the parent. That's critical, and we have to be able to do it. The day of being able to say, oh, well, we don't do that, is fast approaching where it's going to close. We have to be able to address the needs of the child with regard to their parent, the elder parent who has CHF, COPD, pneumonia, any number of ailments, and many of these people have multiple ailments, as you know, multiple conditions that require assistance, and we have to be able to step up to that plate and find that, while at the same time being able to do it in an efficient and low-cost manner.
Mm-hmm. So the first step, obviously, is that you have to have, as they call it, an initial assessment of the person's condition.
Not only that, but it's the condition, but all the social, economic determinants surrounding that individual. You're dealing not only with the clinical conditions, but you're looking at his financial well-being, his living environment. Is he in a safe environment? Does he have support? Doesn't he have support in the home? So you take all those factors into account to be able to develop a plan of care for that individual. That's critical.
Now, if you get a phone call from someone who's sort of not sure of what to do, can you walk us through what the conversation is like?
So if I get a call, I really want to listen. The role here is to be an active listener. Let them explain to me what is troubling them. And sometimes, and not sometimes, oftentimes by asking open-ended questions, tell me a little bit more, and then regurgitating or rephrase it in a manner that they can understand, and they'll say, yes, that's my concern. Now you've got a building block, a piece, a foundation that you can build from. So it's really trying to get, in their words, what the issue is. Because a lot of times, what the issue, as they perceive it, is not really the issue. It's something else. And from there, you try to help them. For example, sometimes it could be that my mother is hurt at home, and I don't know what to do. And so you begin to ask, well, tell me her age, what's been going on? Has she gone to the doctor? Well, she refuses. What about if I'm able to get you a physician to come to your home, to your mother's home, to see your mother? Would that be helpful? Oh, yes. Well, that's an opener. And let's see what happens from there, because maybe from there may be a need for a nurse. There may be a need for therapy. There may be some other needs. Or there could be a situation, well, my parent doesn't trust anyone. Or it could be a language barrier. So you try to bring a nurse or a doctor who can speak that language into the home setting. Sometimes it could be behavioral issues, so you want a social worker involved. So there's a lot of different factors. One thing I will say, though, when you're talking about skill care, which means nursing, therapy, social work, everything starts with a physician order. for Medicare to reimburse, you need a physician order to sign that indicates these services are needed. So that's the first line. Of course, there could be some other needs. There could be a need for some care for an extended period of time, maybe 4 hours in the home. Then you need a caregiver. You don't need a physician order for that, but you need individuals who are trained to provide that care in that setting and can address the needs of that particular client at that time.
So then Metro actually covers the 5-county area, does it?
Correct. We really go from Monroe all the way up to Oakland County, to the east, Macomb, and then to the west all the way to Livingston County. So we cover those, basically 4 or 5 counties, yes.
Well, you know, since in our introduction I referred to your Metro being involved with personal care,
yes,
as well as palliative care. Take a minute or so and discuss the difference
between palliative. Palliative is if you look it's really interesting. Let me phrase this in this way. Older individuals know about Medicare. They really know much more than you or I. They know it inside out. Unfortunately, Medicare has not defined palliative. It has really been developed over time, and it's really about providing quality, comfort, and management of your meds for some individuals who are on a condition that's declining. They may not be ready for hospice, and maybe they're not ready to give up curative treatment. They're receiving some treatment. Hospice really is a Medicare term that was defined, which means you have a prognosis of 6 months or less if the deceased takes its normal course to live. Well, palliative could be much longer than that, and it can be for any age, and you can still receive curative treatment. So what you're looking for is, can we manage your meds? Can we relieve you of pain? Can we provide you comfort in your home setting so that you're able to sleep? People who have CHF, COPD, who are having difficulty eating, who are having difficulty sleeping, all those individuals with those kinds of symptoms probably need a palliative consult to see if it can be managed. And how we've changed it in our organization is we provide palliative care in the home setting so that our physicians work with a patient's primary care provider, a PCP, or can eventually take over the case. It all really depends on what the needs of the patients are and what the needs of the patient's PCP will be.
And PCP,
primary care provider, their physician. In the old days, it was called their general practitioner, right?
Right.
The doctor they go to see the most.
The most.
That's really what it's about, and that's what we're going back to. If you really think about the old days, about a general practitioner, healthcare reform is really trying to aim to go back there, where there's a realization that care, the best outcomes, the best care, the best experience is in the home setting, not in the hospital, not in an institutional setting like a nursing facility.
Only if you have to go. There's some great nursing facilities, and I know you know quite a few of them,
yes,
as well as myself. And as you know, I'm a pharmacist, and I want to pick up on something that many times get overlooked, is the value of the pharmacist in terms of being the quarterback of a patient's being able to stay in their home. And
that's right. Let me just comment on that. Your role is critical. And you know where your role is critical? In med management. Because that's one of the leading causes of hospitalization, rehospitalization. And another leading cause for death, mortality, is there's mismanagement regarding the meds. Just following, sometimes as individuals grow, they're going to 4 or 5 different pharmacists. Well, do the meds that you're getting from one pharmacist align with the meds from another pharmacist?
Right.
A key suggestion that I always give people is just go to one pharmacist. All the records there. And incorporating that pharmacist into the team becomes critical.
Right. Well, you know, I maintain my pharmacy license,
Good.
and I frankly worked too hard to get it, so I ain't losing it. Even though I don't count pills anymore. In fact, the irony is now that function has also been replaced with computers. You can count them by automation, but it is so vital to remember two important things, and I want to make this message as clear and concise as is possible. Those medication organizers that you see, and I'm sure Metro home care nurses know them, are so vital because you can monitor whether they're taking their medications properly. And if you see that the medications are hopscotching all over the dispenser, you know you're in for problems.
That's right.
So the point is that that's part of what I know Metro does, is that they do check their medication.
That's the first thing you do is when you do a start of care is you do a medication reconciliation to try to determine what's there, what needs to be organized, how to organize it, to report that back to the primary care physician, and get that all lined up, so that eventually, what the goal is to have better care, reduction in having to get called in emergency back to the hospital or being readmitted back to the hospital. That's critical. So med management is a beginning process. In fact, best studies now are showing, best practices are really showing that having a pharmacist as part of the clinical team is critical.
Right. Well, and the truth of it is that a pharmacist many times can offer suggestions on which generic drug is appropriate. And in all due respect, the doctors are really trained to be diagnosticians, and having them as a team. And there's there's a lot of things that and the hierarchy and rigmarole that goes on now with high-tech stuff, that you always want to make sure that you have some sort of a file folder with your medication condition on an ongoing basis. I recommend that for a small investment. In fact, one of my close friends, Dr. Andre Lee, has got this neat little book. It's a paperback book that on tying in loose ends.
Absolutely.
And it gives you a step-by-step approach. And here, this is your medical history. This is who the doctors are. And these doctors that you send out to the homes are not necessarily competing with the existing doctors the patient has, right?
No. Well, no. The whole role of a house call physician is really to support the needs of a primary care physician. The reality is that there are individuals who cannot get to the physician. So how do you bring the care to the home? And that starts with a physician. To be able to, for that physician who makes that house call visit, then reports back to the primary care physician. His role is not to replace him. In some cases they could, but that's not really the goal. It's really to provide the added support.
Right. Well, I'm really excited that the technology indeed can really, as they say, make it almost a seamless transition, because you have the home care doctor, and now with smartphones, you can actually see the other doctor.
The wound.
The wound, right.
Exactly.
Right. So it's exciting in that we can use technology to replace a lot of the reasons that many people ended up in a nursing home or an assisted living center. And there's one company that I know out there that I've had on my radio show, and they actually can do the blood pressure and glucose monitoring over the phone lines. So now,
yes, there are.
So think about it. You can actually see and stay in your own home.
That's right.
And it's a known fact that seniors especially fall in love with that environment, no matter how small that bedroom is. It's their castle,
That's
their domain. And of course, there's, from a practical standpoint, adjustments that you have to make in the home. Now, I know from having talked to the people at Metro Home that you've got physical therapists, occupational therapists, speech therapists, and I just wondered, there's a gray area between occupational therapists and physical therapists. Can you address that?
Well, sure. In occupational therapy, I might call that it's the ability to, OT comes in to really provide that support to get you to be able to maybe train you or retrain you to pick up the glass, as opposed to physical therapy. So you're dealing with those everyday skills that you need. While physical therapy is really about larger efforts in terms of exercising your body maybe to prevent falls, which is a common occurrence among seniors. That's another leading cause to hospitalization. That's where physical therapy. So sometimes you may have a stroke. Some people may have a stroke and they require retraining to do certain exercises or certain skills like picking up a glass or a pencil, and that's what OT is about, occupational. How do you get them to?
Well, I have it got me through school. I used to associate different terms with something that I could memorize. And I think of occupational therapy as the outside part of
You're right.
And they'll check out, hey, your counter is higher than it should be, so you can bring people in, and we're affiliated with various renovation type services like that, so that the whole aspect of picking up a glass, they've got these cups that are two-sided and have the handle on the appropriate side. Or you're dealing with OT coming in and how to make your house safer, right? How to make your house, how to set up certain support in your home setting so it can be safe for you to walk around. And that's also important. That's really what an OT can do much better than a PT. They take care of the outside of your body.
They
and
take
the
care.
Physical takes care of your body.
They take. Yeah, I like that. That's right.
And then, of course, the practical part, like you mentioned about a stroke. How many times, unfortunately, if you had a stroke and you have the handrails on the opposite side of your stronger side, so they can adjust for that.
Absolutely.
And somebody from the outside can come in, and Metro has these the different type services available. Yeah,
you know, building on that, OT, PT, and even nursing, a wonderful add-on to that is having the caregivers who are there who can watch what they're doing and then provide the caregivers the training to be able to follow it up every day thereafter. Because what happens is Medicare, what they're providing is referred to as intermittent, meaning once or twice, maybe 3 times a week. But OT and PT is needed every day. So that's the role of a caregiver, either to hire someone to come in, be trained to help that individual when the PT and OT is gone, to continue those exercises every day, and you'll get stronger.
Right. I wanted to highlight the remark you made earlier that if it's a medical procedure the doctor has ordered, that is covered by Medicare.
That's right. Now let me explain that. In home care, in home health, there's really 2 criteria. You have to be homebound, which means you have difficulty leaving the home setting. And that's a term of art that's defined by Medicare. And the second is there has to be medical necessity in the home. A necessity for medical services like OT, PT, speech, nursing, social work. And to either provide some training, to provide some rehab, or to avoid any further decline. But to bring those skills services, you need a physician-signed order.
And again, As long as it's medically related with a doctor's order, the patient does not have the out-of-pocket expense.
That's right.
And
there's no copay under Medicare.
Mm-hmm.
Now, I will tell you that some individuals, seniors who turn 65, may opt for a Medicare Advantage plan. Mm-hmm. Now, if they opt for a Medicare Advantage plan, they need to look at their particular plan to see how home health services are covered.
See, that's why you're president of Metro Home Care. See, because you know all this stuff, and you're an attorney as well.
Well,
it's been
right.
a delight talking with you.
Oh, thank you, Ike.
And we've run out of time on this particular topic. We'll have you on again, and I like to leave my program with one of my favorite remarks, which is, yesterday is history, tomorrow is a mystery, today is a gift, and that's why we call it the present. Please enjoy your present by living life in its full, by looking at the bright side of aging.